My name's Teresa Allison, and I have the privilege of introducing our speaker, Dr. Tacara Soons. And those of you who are in the speaking thing, please ignore the fact that I'm reading off of it and clinging to my podium. Dr. Tacara Soons is an associate professor and the chief of geriatric medicine at the University of Texas MD Anderson Cancer Center. Her career is dedicated to improving quality of life for older adults by moving healthcare out of hospitals and into the homes and communities where we age. While on faculty at Mount Sinai Hospital from 2014 to 17, she was a clinician and investigator on both a CMS Innovation Center clinical grant and a John A. Hartford Foundation evaluation grant to model hospital care at home. Dr. Soons is now leading an innovative oncology hospital care at home pilot at MD Anderson Center in Houston. But what you might not know is that Tacara started her home medical career here in the UCSF Division of Geriatrics, where she learned the first rule of house calls. Do you all know the first rule of house calls? So you might have heard that it is fill your stomach, empty your bladder, and leave your personal baggage in the trunk. This is a great rule, but the first rule is take your allergy medications. The homes are full of dogs and cats. Sneezing or not, it is an honor and a delight to welcome Dr. Soons back home and to hear about her innovative approaches to home care medicine.
Thank you so much, Teresa, for the amazing introduction. I have no relevant disclosures. Hi, everybody. There's so many familiar faces. When I think back on my career, it's probably most important to start with this photo. I want to tell you about one of the first patients who was enrolled in hospital at home in the United States in the early 2000s. This cat is not Walter. Walter was one of the first patients. He had multiple chronic conditions, including COPD and heart failure, many admissions for the same, and refused to go into the hospital. He said every time he went to the hospital, the food was terrible. He got delirious and was tied down, and there was nobody to feed his cats. So hospital at home really started in geriatrics, obviously in the early 2000s for these older adults with multiple chronic conditions, saying, how can we do better for them? So today we'll spend our time talking about what hospital at home is, what is the model, what's the evidence for the model, what are some opportunities and challenges in hospital at home, and then I'll spend some time talking about the work that we're doing at MD Anderson. So hospital at home has what I see as 6 foundational blocks. One is that you need a patient, obviously, who needs hospital level care. You need skilled home staff. So in most cases, that's nurse practitioners, MDs, APPs, as we call them. You also need nursing support. You need infusion support. You need individuals who are able to respond to patients' needs 24 hours a day. In the wake of COVID, you also need robust virtual care and monitoring. When we first started our hospital at home program in Mount Sinai in early 2014, we did not, or it was 2014? 2014, we did not have this expertise yet, but now there is so much digital information available that we can support our patients 24/7 with telemedicine, with in-person or telemedicine visits as needed. You need technology for remote vital sign monitoring. So how can we make sure that our patients are stable in terms of their blood pressure, vital signs while they're in the home? One of the biggest challenges for hospital at home programs is this redundant supply chain. You need to be able to offer the same level of care, the same services in the home to meet patients with their basic needs, including x-rays, labs, durable medical equipment, and pharmacy supplies. These services need to be available despite what's happening in your city at the time. So we always say in New York, you can get food or whatever you want in the middle of the night, but you cannot get oxygen in the middle of the night. One of the, I remember as the most foundational experiences I had in hospital at home in New York was a patient who needed an x-ray, lived on the 15th floor in public housing and the elevator broke. So what do we do? How do we offer standard of care to patients when the system is really challenging? Hospital at home will always be based on patient preference. There are patients for whom it makes sense to be in the hospital. There are others for whom it does not. For example, if their caregiver needs respite and the hospital is seen as an opportunity for that, that's a patient who's probably going to refuse to participate in your program. You also need a payment mechanism. So as I say, we need a way of reimbursing the hardworking caregivers and healthcare providers in the context of the care that they're doing. So when we think about a patient like Walter, this is what a hospital at home journey can look like. He'll receive certain visits in the home, including a physician or an advanced practice provider. Usually somebody like Walter would get twice daily nursing visits for IV medications, infusions, oxygen as needed, labs, x-rays, ultrasound as I described. Most programs also offer home health, meal delivery, and then 24/7 emergency support, so EMS or paramedicine. The remote services include this 24/7 call center. It's really important that when a patient calls, they get a person and not an answering service when they're having an emergency. And then remote vital sign monitoring. After a patient has recovered from this acute episode, they can be discharged home to their primary care doctor. When we think about hospital at home, most of us are, I think, used to understanding this in terms of a patient with hospital level care. And so, how do we meet those needs? But once you have individuals in the field who are able to provide services in the home, the hospital at home platform is actually quite flexible. So, while we'll spend most of our time today talking about what we call admission avoidance hospital at home, I wanted you to be aware that these other models exist, and we'll spend some time talking about them at the end. So, if you change the time of entry, so most hospital at home programs have patients coming through the emergency room, and we call that admission avoidance hospital at home. But if a patient starts their hospital stay and then completes their hospital stay at home, that's either called early discharge or early supported discharge hospital at home. If you think about this program and the skilled home staff piece is more physical therapy, occupational therapy, speech, and less about the physicians and nurse practitioners, that's often called SNF or rehab at home. And then secondly, in cancer care, we think about chemotherapy at home. When you think about more patient-reported outcomes, so for example, symptom monitoring, urgent care visits, hospice and supportive care at home, those are supportive care at home or clinical trials at home programs. The redundant supply chain, patient preference, and payment mechanism do not change. So when we talk about the model evidence, we're going to go way back to 2000 or the early 2000s to go over some of Bruce Leff's first work. So Bruce Leff was a physician, is still a physician at Hopkins, and the first study of hospital at home was done, as I said, in the early 2000s in the United States. It's important to keep in mind that this model has existed in other countries, in Australia, in the UK for much, much longer and much more robust program. So it's not a new concept even in the United States. This first study was a prospective quasi-experimental study, so the controls were observational patients, patients that were enrolled or admitted to the hospital from 2000 to 2001 and received usual care. From 2001 to 2002, he identified patients at admission and offered this admission avoidance hospital at home. There were 455 community dwelling adults over 65 enrolled. They had to meet inpatient admission criteria by the emergency medicine physician, live in the catchment area, and at that time it was limited to 4 diagnoses: pneumonia, CHF, COPD, and cellulitis. They obviously had to meet validated clinical criteria and that you want your patients to meet inpatient criteria but be unlikely to decompensate in the home. They received daily physician visits. Interestingly, this first iteration involved in-person nursing, so a nurse in the house for the first 8 to 24 hours, which it turns out patients don't really like. So that did not last, as well as the same services we talked about before. Interestingly, the acceptance rate, so this is at 3 sites, the acceptance rate for 2 of those sites was only 69% for enrollment in hospital at home and even lower at 29% for one of the other sites. The differences between the observation group and the intervention group are important to note. More observation patients were living alone. Their Charleston comorbidity index was the same. The mean Apache score between the 2 groups is 1 point different, but some of you may know that the Apache score runs from 0 to 70, and so a 1 point difference may not be clinically significant. And patients received different care in the home. The same number of patients received IV antibiotics, nebulized bronchodilators, but rates of things like IV fluids and difficult procedures and consultations were different. Difficult procedures are things like telemetry, CT scans, things that would be difficult to offer in the home. And as I mentioned, they had more consults in the intervention group than the home group. So one of the most important questions is, if there were differences in care, were there differences in outcomes? So delirium rates for the intervention group, for the hospital at home group, were lower. Emergency situations were about the same. Critical complications were lower. The care escalation rate is the rate at which patients were brought back to the hospital from the hospital at home group, and that rate was 2%. And people really started to pay attention to hospital at home at this last outcome, which is that the length of stay was a day and a half shorter for patients enrolled in the intervention group. So additional studies came out from Bruce Left's work, as well as a second integrated healthcare system that I'll talk about in a minute. While there were potentially differences in patient selection bias, patients were more satisfied in the hospital at home group, with 84% satisfaction among the intervention and 67% of the highest rated satisfaction among controls. And then costs were significantly lower, again, in the intervention group than in hospitalized patients. One of the oldest hospital at home programs in the United States is in an integrated healthcare system called Presbyterian Healthcare in New York. They did an independent analysis and found that hospital at home actually lowered their cost of care by about 19%, and that the majority of this cost reduction was seen because of reduced length of stay, as well as fewer diagnostic tests and labs, again, without decreasing patient experience and patient safety. One last study that I'll go over, this is a meta-analysis, and it looks like all three boxes. There we go. Okay. In yellow, there's no difference in mortality. So again, we're seeing that patients can be cared for in their home without worsening patient safety. Readmission rates were better among patients in the hospital at home group than patients at home. This study involved 9 randomized controlled trials, only one of which is from the United States, and involved 24 patients, but the majority were from Europe, particularly from Spain and Italy. So the models may have been slightly different. The length of treatment was significantly longer for the hospital at home group than for hospitalized patients, but they were, again, slightly better in terms of discharge to long-term care after admission. So based on all this data, the Mount Sinai Health System really started to pay attention. Folks at Mount Sinai, Bruce Leff, Linda Cherry, applied for a CMS Innovation Award. So CMMI is the Center for Medicare and Medicaid Innovation, and was awarded a $10 million grant from Medicare to model what hospital at home would look like under fee for service. Despite the wonderful data from the early 2000s, uptake was really nominal, I would say, because there was no payment mechanism for a hospital at home under traditional Medicare. The second grant they got was from the Hartford Foundation to do the evaluation, and I'm happy to have been a part of both of those grants. So Mount Sinai Health System really had a couple of things going for it in terms of their ability to do this program, and I think, as we'll talk later about deciding to do a hospital at home program yourself, it's really important to think about your own healthcare system's capabilities. Mount Sinai's had the skilled home staff start here. It's one of the largest academic house calls programs in the country, and really had those relationships, not just on the physician and nurse practitioner side, but also in home care. In terms of redundant supply chain, again, that's that home care perspective. They had relationships with companies that could do infusions in homes, x-rays in the home already. And then this grant was meant to answer that last question around payment mechanism. So we designed this as a case-controlled study. Our patients were enrolled in hospital at home, and then any patient who presented to the hospital on nights and weekends became a control, or if they refused participation in our hospital at home program at the time, that was called MACT. Patients were identified in the ER and then enrolled directly from the ER to go home with hospital at home. We enrolled 507 community dwelling adults over 18. So this is not a program just specifically for geriatric patients, but any adult over 18. They had to meet admission criteria by Milliman, live in our catchment area, and we expanded to 19 target diagnoses. So thinking about this more as what are the services that we can offer in the home, and how can we meet our patients' needs, as opposed to having 4 target diagnoses. Patients received daily MD or nurse practitioner visits, 1 to 3 nursing visits a day. We had a fantastic relationship with our community paramedicine team, which meant that patients, if we had a concern about a patient, we could send paramedics to the home who, under our direction, could provide medications and interventions, as opposed to, and be reimbursed for that care, as opposed to having to transfer a patient back to the hospital in order to be reimbursed. And we offered, again, the same services: oxygen, pharmacy infusions, et cetera. Part of the modeling for this was around a 30-day payment bundle. So what can we do first during that acute care stay for hospital at home? And then with the infrastructure that we had, how can we continue to support patients for an additional 30 days to prevent readmission? So these are our outcomes. We saw a decreased length of stay at the top among our patients enrolled in the hospital at home program by about 2 days. We had decreases in hospital readmissions in 30-day ED visits. We had fewer patients obviously transferred to a skilled nursing facility. Our rates for home health agency referral were the same. And patients, for the most part, loved our program. I highlight here 2 areas in red. One was around pain control, was not surprisingly difficult to do in the home, and I think it's something that was evolving for our team. But overall, the patient satisfaction ratings were quite high. Based on our early data, the Mount Sinai Health System really got excited about how can this be part of a larger population health strategy. This left photo is a advertisement placed by the Mount Sinai Health System in the New York Times. And then on the right was the beginning of what have now been a couple of articles on hospital at home in the New York Times. So folks started to pay attention. And for me, this was love, I would say. As a geriatrician, the opportunity to be in patients' homes. I know I'm preaching to the choir, but to be in patients' homes and to really see what they were doing with their medications is really important. I'm excited about this work for our patients with cancer. When you think about things like needing to improve nutrition, to be able to look into the fridge or in the cabinet and see the jar of peanut butter and say, you need to increase your protein intake with the jar of peanut butter right here, as opposed to hypothetically what to do, I think really makes a big difference for our patients and really brought me and my team a lot of joy in hospital at home. This is an analysis done by Medically Home, who I know many of you know, pre-COVID. And so this looked at what is the market for a hospital at home. And I think that this is the beginning of when industry also started to pay attention to the potential that hospital at home could provide. So they saw a $300 billion domestic addressable market for hospital at home, where we could substitute 20% of hospital admissions, 15% of SNF admissions, and then begin to think about what clinical trial support would look like. And this was all of the centers offering hospital at home pre-COVID. And as you can see, they're all integrated healthcare systems in some way, so mostly VA hospitals. And then COVID. So one of the, I think the positive things, or maybe the only positive thing to happen as a result of COVID was the CMS waiver. So the CMS waiver allowed for waiving the 24/7 nursing requirement for hospital to provide care. So it provided a way for hospitals to bill for the care they could provide in the home at the same rate as patients would get in the hospital. So as a result of the CMS waiver, the hospital at home is now available or offered by 260 hospitals in 37 states, or 5% of hospitals in the United States. So that's all well and good. We're excited about the model, but there are some challenges. There are some things to figure out, and we'll spend some time talking about these opportunities in the areas of patients and caregivers and equity, technology and clinical operations, quality and safety, and reimbursement. So in hospital at home in New York, 1/3 of patients declined to participate. And that was surprising to us. We built this amazing thing. And obviously, if you build it, they will come, right? But we found that it's, again, not the right model for everyone, that folks have caregiver burden, that there is a lot of sense potentially of mistrust. So why am I being asked to participate in this program at a safety or community hospital? What is it about my insurance or me that makes me eligible for potentially less care? And so a lot of, I think, this work is also around culture change and recognizing that this is an opportunity to provide the same level of care for patients in their home. That's not necessarily less care. One of the most important areas is around task shifting to caregivers. And so nobody, I imagine, who's in the hospital at home world is hoping that this program means that patients and family members are hanging normal saline or pushing IV Lasix. There was a great article written by a health economist just explaining her experience with having her mother and father actually enrolled in a home health agency that I think could have applied to a hospital at home program. Where she said, separate from home health, An oxygen company delivered 3 tanks and a large heavy machine and tubes. Late one night, I found my mother dragging the big oxygen machine across the living room floor so she could give my dad oxygen in bed. She was panicking because his oxygen level was dropping. And so you can imagine that, again, this is not our desire to have caregivers in a role that they're uncomfortable or unprepared to do. And then we think about a lot of other areas, of course, where we know that this program may be different. So how can we, when we're limited by catchment area, how can we make sure that patients who are in rural areas are still able to access hospital at home care? How do we make this a program that's offered both in wealthy communities as well as in the safety net? And then how do we make hospital at home services available to patients living in facilities as well as in private homes? Clinical operations and technology, I think, is one of the more complex areas and one of the areas where many institutions get stuck on developing hospital at home programs. As we talked about before, the supply chain needs to be redundant. So how do you find the right number of vendors in your community to be able to meet patients' needs? How do you manage that operational complexity? So each of us, when we're in the hospital and you order a CBC, you hit accept, and then you move on with your day. You may even decide to change the order, recognizing that somehow the system works this out. But what does that look like when you're in the community? And so you need somebody to go to the house and draw the labs. Is that a nurse or a phlebotomist? Does that person then bring the specimen back? Do they use a courier? How do you manage all of these people? And then again, if the doctor changes his or her mind, then what do? How does that order get to that person? And the last one other thing I talk about is around scaling. And so I've been asked the question before, how do we maintain the essence of a hospital at home program and that really sort of intimate patient provider relationship as you're thinking about scaling programs like this? And I know this is not something that's new to all of you who are in house calls programs or hospice. How do we maintain these excellent patient satisfaction outcomes in that setting? Device failure and security. When you have devices obviously in the home and you have patients with limited internet access, how do we make sure that they're safely monitored? How do we think about the volume of data and remote patient monitoring? So most programs now are offering episodic blood pressure monitoring or single episode reported oxygen. But if folks are wearing continuous monitors, what is an abnormal value? When do you actually need to call? Some of you may have children and may have used those Owlet device monitors. So how do you know when your child is actually desaturating? Same idea. There are EMR limitations. So as we talked about before, when you're trying to place an order, how do you coordinate all of these things across multiple different environments? Most of our EMRs are not meant to do that. Epic, for example, is not meant to coordinate or to offer the same level of support it has on the inpatient setting to patients in the clinic. And lastly is overtreatment. So most programs decide that for somebody to be enrolled in the program, they have to meet minimum criteria. But how do you can kind of fudge that a little bit? And we've definitely seen providers who want the best for their patients. So maybe they want to upcode to receive hospital level services in the home because they don't quite want to admit them, but they don't really want to send them home. So how does hospital at home make sure that we're taking care of the right patients without increasing costs? Quality and safety is important. There are pre-COVID, there were no accreditation standards for hospital at home programs. So there was a lot of heterogeneity. In order to decrease heterogeneity and obviously improve patient and provider perceptions of liability, there needs to be standardization of what a hospital at home program offers. The CMS waiver has done that for programs who apply for it. But outside of that, there's really no accreditation standards for what your hospital at home program should look like. And that heterogeneity really impacts the ability to move legislation forward to be able to offer hospital at home on a larger scale. Lastly, when we think about reimbursement, most programs are thinking about it in 3 areas. So direct revenue, so how can I bill for these services that are provided, or how can I think about this in the context of value-based care? What's my indirect revenue? So how can I attract new patients to my organization for offering this fantastic hospital at home program? Or how can I shift patients within my institution to a lower cost setting? And then lastly, how can I backfill beds in the hospital? There are no clear answers. Every institution needs to do their own analysis. And then many programs are thinking about now what happens after the public health emergency. So as we all know, that expired. This is The CMS waiver was extended for 2 years, but in that 2 years, the institutions doing hospital at home and CMS are meant to figure out, again, what these accreditation standards should look like, and is this a benefit that they want to continue offering beyond? So let's talk a little bit about MD Anderson and what we're doing. So obviously the most important question is why start a hospital at home program? As I talked to the fellows about, it's not enough to say this is the right thing to do. As a bleeding heart, that's what we try, but it really has to be framed in these ways. And so at MD Anderson, we're looking to enhance our patient experience. We want to deliver oncology care in the most cost-effective setting and reduce inpatient utilization. And MD Anderson in particular is interested in our institutional capabilities in the virtual care environment. This is very much still hands-on, but offering that virtual care support may allow us to expand into some of these other opportunities that I've talked about, like supportive care at home, where we're doing more PROs. If a patient is having increasing symptom burden at home, hospital at home can give us some of that network to address our patients' needs. And we've couched this, and in order for our hospital at home program, I think, to be successful, I've thought we've had to think about this within the context of the larger institutional strategy. Hospital at home programs, as you can imagine, involve a tremendous input of finances and institutional capital. And so again, for us to make the case for this program, it's had to be coached in our larger institutional strategy around reach, breakthrough, and value. And I won't go into those in detail, but just know that we use this terminology. How can we use hospital at home to extend our reach into Texas and into cancer? How can this be part of our breakthrough? So part of developing an innovative research portfolio for MD Anderson, and then how can we think about this in terms of the additional value it will provide? We also have spent a lot of time looking at the data coming out in cancer in hospital at home. Huntsman at home has the probably most robust hospital at home program within the oncology setting. They offer a variety of services. They offer early discharge, meaning patients start their hospital stay in the inpatient setting, and then they complete their hospital stay at home. They offer some admission avoidance and mostly supportive care. They do not currently enroll patients directly from the ER, but they've shown tremendous improvements in patient outcomes. So decreases in unplanned hospitalizations, reductions in costs, as well as decreasing length of stay in their patients. A couple of other institutions are also working on hospital at home for patients with cancer. MGH is one of them. They're now doing a feasibility trial primarily for supportive care at home. So number one is just patients with specific cancers. Number two, folks admitted with advanced cancer. So how can we help those folks with end-stage malignancies? And then how do we think about a hospital at home portfolio for folks with hematologic malignancies? This is an early outcome study or a feasibility trial that also showed really robust improvements in emergency department visits and again, those healthcare utilization outcomes that we care about in patients with cancer. MGH is also doing an innovative surgical hospital at home. How do we think about this portfolio? Once MGH has multiple people in the field doing hospital level care at home, how do we use them to our best capability? The patients are primarily those folks who are post-colectomy, so they'll come into the hospital, they'll have their cancer surgery, and then be discharged with hospital at home. And then a couple of other diagnoses here, most of which are planned admissions. So for things like prostatectomies, the last two groups are folks who are coming in after surgery with symptoms, so potentially from ostomy dysfunctioning, vomiting and dehydration from the same. We had a 24 patient pilot. The primarily patients were early discharged. So again, those planned admissions where folks went home right after the ER. One of the things I found interesting about this pilot in particular is that for the 24 patients, there were also 24 house calls done by surgeons. And so as we think about, and so those numbers in parentheses are the number of visits done by each group for the 24 patients. And so, for example, there were 54 nurse practitioner home visits for the 24 patients in their pilot. They didn't specify if those 24 visits were one each per patient, or if there were patients who received multiple visits, but at least in their model, an internal medicine doctor did not fully substitute for the expertise of a surgeon in the home. And how do we think about developing these programs, particularly at a place like MD Anderson, where patients have cancer, without surgeons who are used to doing house calls? Can we develop that expertise in some other way? So, as I mentioned before, every institution doing a hospital at home program needs to think critically about what its strengths are and how to augment those. We obviously have many patients needing hospital level care at home. MD Anderson has not had a footprint in the house calls world before. We don't have home-based primary care. We don't do primary care. There's not. It's a state institution, so there's also not been a preferred vendor for a home health agency. So that those relationships do not currently exist. Same for redundant supply chain. While we have patients who definitely want to go home with these services, there's also not a payment mechanism that we have to be able to do this. MD Anderson is DRG exempt, which means that we are not eligible for the CMS waiver. So, as we have started this work, we decided to partner with a vendor named Dispatch Health to do our house calls, recognizing what our strengths are. And so, we'll talk a little bit about some lessons learned from interviews that we've done with patients, providers, and caregivers prior to launching the program. And then I'll spend some time talking about what our model actually looks like. So many programs have seen this first one, which is the challenges with physician buy-in. So many populations, many providers think that their patients in particular are too sick to be enrolled in a hospital at home program, and we're seeing the same thing with our providers. So we've worked with our oncologists to really co-develop a program to increase their buy-in. And one of the most important parts of this is that we're launching in July. And so hopefully we're enrolling our first patient around July 17th, and really making sure that each and every patient that we enroll, that we're feeding that information back to oncologists to say, look, you admitted Mr. Joe and he did well, send us more. We're also seeing that our emergency room physicians are uncomfortable with discharging patients. So in our model, patients are being discharged to the care of our vendor, but we're saying that these patients need inpatient level care, and then we expected them to hit the discharge button in the emergency room. Folks were not terribly excited about that. And so one of the ways around that was we created a specific button within our EMR that says discharge to our program, which is called Care and Monitoring at Home, or CAM, to allow them to be able to say, I'm not just sending this person home with nothing. Our patients, caregivers, and providers were all very anxious about the lack of integration of our electronic medical record with that of our vendor. And so they wanted to know how we're going to make it possible that when a patient has something happen in their hospital at home or care and monitoring at home experience, that their oncologist knows about that. And so one of the ways that we have really tried to not just integrate the EMR, but really integrate MD Anderson into care provided by a vendor is to have one of our MD Anderson hospitalists on a daily huddle or daily phone call with the vendor's team. That way, information is still documented in our EMR about test results and decisions made, and that if a patient needs to come back to the hospital for any reason, all of that documentation is already in our system. We had patients and caregivers, and still do have patients and caregivers who are concerned about working with a vendor. Many patients come to MD Anderson for MD Anderson care, and we're now saying, great, welcome to MD Anderson, and then go home with these other folks. And so again, we're trying to augment that by embedding one of our hospitalists in the vendor team. They won't be doing house calls, but they'll be helping the hospitalist, the general hospitalist, with our vendor making those decisions. And then we'll also have them call patients to say, thanks for enrolling in Care and Monitoring at Home. I'm Dr. Soons. I'm going to be on the phone with Dispatch Health every day taking care of you. So you may not hear from me, but know that I'm here. And so many of the things that we are trying to do is around creating a seamless relationship between us and our vendor and the patient. Many patients and caregivers really want, if they're enrolled in a program like this, to be able to come back directly to the hospital without going to the ER if they decide to enroll. And that, as you can imagine, is slightly difficult. So we're exploring how to make that work. And then lastly, I would say patients and caregivers are really excited. They're excited about the ability to be able to not just do hospital at home, but to do all of these other services in the home, to do clinical trials. So as some of you may know, when folks have clinical trials, they may be coming to the hospital, paying for parking, sitting for hours, for many days in a row to get labs, to get monitoring. And so to be able to do that in their home for patients and caregivers is a tremendous ability to spend more time doing the things that you want to do. The same thing for post-operative care at home. So for folks who are getting more basic surgeries like colectomies or ostomy reversals, can we take those patients right after they come out of the ER? Can we do chemotherapy at home, and can we do supportive care at home? So we're thinking about all of these after we do our feasibility pilot. So our pilot for care and monitoring at home is going to be 1 year. We're expecting to enroll about 40 patients. Our most important outcomes are escalation of care. So what percentage of patients have to come back to the hospital after they've been enrolled in care and monitoring at home for any reason. So if the patient doesn't like it, if they are too sick to stay at home, that's our primary outcome. We're also looking at 7-day healthcare utilization, so ED visits and readmissions, the same, which, as you may know, 7-day hospital utilization more reflects difficulty with discharges. So was there something that could have been done during that initial hospital at home admission to help improve early care, as well as 30-day healthcare utilization and patient satisfaction? The pilot will involve only patients with solid tumors. They again have to meet hospital level care. We're expecting that these will primarily be clinically stable admissions for supportive care, non-critical infections like non-obstructive pneumonia. Patients will need to stay within 30 miles of MD Anderson. One of the important things to keep in mind about MD Anderson is that many of our patients are not local. They're coming from all over the state and all over the country. So will adoption look different, when somebody is staying with an adult child nearby, or in a hotel attached to the hospital, or in short stay housing? And because of our contract with a specific vendor, we're limited to patients with Humana Medicare, and that's why the pilot will be small. Patients will get the same services that we've talked about already. Daily MD, usually APP visits, so nurse practitioner, PA, nursing visits, community paramedicine. And the model is shown here. And so one of the things about our vendor, the vendor services are shown in gray. That way you can clearly see what they'll be doing in the home. And then the MD Anderson services in green. They offer not just the initial hospital stay, but then 30 days of remote support or as needed in-person urgent care visits. So this is my one of my next to last slides. Many programs are thinking about hospital at home, not just as admission avoidance and what can we do, but once we have all of these people, this infrastructure built, how can we utilize this to meet all of the needs of our patients? So when I think about oncology at home, it's this acute care piece. How can we avoid admissions and directly admit patients from the ER? One of the challenges with patients with cancer is that many need imaging, either CT scans or MRIs, to help decide, do they need a specific procedure to address their symptoms? And so there may be some challenges in admitting patients directly from the ER when the emergency physician just wants to hit the admit button and let the patient keep going, as opposed to holding them and waiting for that initial read to come back from their imaging. Can we do early discharge in the future? So again, having an opportunity to have the patient stay in the hospital, maybe get a tube or a stent. If they need additional imaging for our labs for a couple of days, can we then bring them home? Supportive care is a big piece of what we're hoping to do around remote patient monitoring and supportive care. So how can we have patients report their symptoms and then be able to address them without them having to come into the hospital? And then similarly for on-demand, it's urgent care visits, labs, infusions, chemotherapy, and clinical trials in the home. So we've covered a lot today. Hopefully you have an understanding of the building blocks of hospital at home. You've seen the structure several times, that patients need hospital level care. We need skilled home staff in order to be able to meet their needs, virtual care and monitoring supply chain, patient preference, and payment mechanism. That hospital at home in general can decrease costs and potentially 30-day healthcare utilization with excellent patient satisfaction. We need additional research on caregiving and the impacts of hospital at home on this population in particular, again, to make sure that we're not shifting services to adult daughters and significant others in other ways. That the Medicare benefit, if there is going to be one, needs to be supported by accreditation standards. At MD Anderson, we've made the decision to work with partners to help us with those areas that we have not had strength in before. So thank you, and I will take questions. Of course.
Tacara. That was just a fabulous talk and such a compelling case for this model. I'm going to give you a plaque in appreciation of being one of our visiting professors.
Thank you so much.
It says a teacher affects eternity.
Oh,
So,
thank you.
so we're very appreciative of being here. So I will open it up for questions. Maybe I'll take the prerogative and ask the first.
Sure, but you've got a hand over there too.
What was that? I'm going to ask the first question.
Yes, please.
So, I'm curious about your vendor. And sort
Yes.
of the plan, is that to sort of get things up and going, prove the case,
Mhm.
and then build it within your division? Or how, I guess I'm just curious on sort of thinking
What's the
about
long
that.
term? Yeah, that's a great question. So starting a hospital at home program, as I mentioned, is a tremendous investment. So a healthcare institution needs a very strong reason for that initial financial investment. We were able to convince them to do the pilot, that we think this is the right thing to do for patients. It can be part of a larger strategy. But we weren't able to convince them that it's worth investing $1 million just yet. And so the pilot helps us prove feasibility. The vendor has an out-of-the-box solution for hospital at home. That means that we did not have to insource those pieces. But I think in the future, the conversations will need to be around how can we do this financially together? Or, how do we start insourcing a program like this? Mm-hmm. Yeah, of course. Mm-hmm.
We're talking about not burdening families and caregivers. There's obviously medical needs, there's timing, et cetera.
Yeah.
We know also acute and sick people have increased ADL needs, IADL needs.
Yep.
So is that just landing on families, or is it,
Right.
how do you take care of that?
Good question. So some programs are offering home health aides to help with that ADL needs. I would say that for patients who already have a caregiver in place, and that caregiver is willing and wanting to keep somebody home, it makes a lot of sense for enrollment. If you have adults who have new 24-hour care needs as a result of their acute illness, they're probably not great candidates, because what we found early on was that if you offer a 24-hour home attendant as part of your service, not only does the cost of care you provide skyrocket, but then how do you think about discontinuing that service? There's not a clear endpoint. So I think part of it is patient selection and making sure that you are meeting those ADL needs in advance. Yes.
So I'm coming at this from an ED
Yeah.
perspective. So in terms of throughput, so you talked about convincing ED providers about this model and about transitioning patients from hospital to home. What's the time frame to eligibility? Like, how long is that patient going to have to sit in an already overburdened environment to get them to eligibility decisions?
Great question. So one of the things we found at Mount Sinai was it was helpful to work with our ED providers and our observation unit to figure out if there was a delay, if it was going to be more than 4 hours, where can we keep those patients? For our iteration at MD Anderson, we are not planning to hold folks in an observation unit or in another space in the hospital to determine eligibility. But depending on the financial needs of the institution and their reasons for doing that, they may consider holding people in diverting that throughput elsewhere. But you're right that we cannot keep patients in the ER for longer than they would have been otherwise if they were not admitted for this program. One of the challenges, and I think where lots of people would like to see these programs go in the future, is that is the patient selection piece. And so, the first iteration for the Mount Sinai program, it was one of the Mount Sinai hospital at home team who was going to the ER, evaluating every person, talking to the ED physician, writing the orders, trying to figure out where to put people. That's not sustainable. But in the long term, what you'd really love to see is that an ED provider can say, this patient goes to hospital at home, this patient stays in the hospital, this patient gets discharged home. But you need a couple of things in place in order to be able to do that. Usually you need an EMR in place to really help with patient selection and identification. And then you need enough payer availability so that ED providers are not constantly told, no, your patient's not eligible because they don't have the right insurance.
One question from the Zoom world.
Yes.
It builds on the eligibility criteria. They ask if there is a different eligibility based on if the person lives alone or has a caregiver versus someone who has a caregiver.
It depends on the program. And so for early programs, they always required a caregiver because there was a lot of discomfort around what happens if a patient has an emergency in the home. Most programs now have relaxed that requirement, that if you are a single adult who wants to be home, who has a COPD exacerbation, you can reasonably be expected to get on your iPad or get on your phone and call for help, that you can enroll in the program. But I think it just depends on the threshold for that program. Yeah.
Great presentation.
Oh,
So
thanks.
interesting. And it's cool to hear your involvement. Can you share a little bit about what the discussion has been like around reimbursement, particularly as it relates to scale? Because you can demonstrate efficacy in a small selected cohort, and yet as you scale, the number of people it applies to invariably drops off. And I'm just curious to know how you handle that as a physician, because you're actually there, and so you can kind of see where they might fudge some of the numbers because it might be financially advantageous, but it doesn't cleave necessarily to how the program is working. So how do you reimburse this fairly?
You're asking a really challenging question, and I'm not sure that I have a good answer for you. You know, the care can change, obviously, as the program scales, and you have to think critically about being able to provide that same quality. I would say many of the groups in industry now who are developing hospital at home programs are thinking, gosh, anybody can offer ceftriaxone or another IV antibiotic in the home in 5 years. So what is going to differentiate my program from other programs? And so they're thinking more about what are the other services that we're providing in the home? Can we address social determinants of health? Can we really get to the root of why patients are being readmitted? So I think that I'm hopeful that that'll continue to be the case for industry as they're thinking about scaling. The conversations around reimbursement have really, I think, pushed this field to think about standardization. And so the saying used to be in the past that if you've seen one hospital at home program, you've seen one hospital at home program, because they were all so different. They were built from the specific capabilities of a particular institution and what those institutions' needs were. But that's not how healthcare is done, right? We're supposed to have as a patient, you're supposed to be able to enroll in a hospital at home program at any place in the country and know that you're getting the same standard and level of care. So I think some of these things are still developing, and we've got 2 years to figure it out. And we'd obviously love to have people like you on our team who are asking these questions. Yes, Robbie.
Goes into accreditation now for hospital home programs, and what are the big blind spots in your view? Like, what is missing from the
So the waiver covers specifics around the care. So meaning you need 2 nursing visits, you need to be able to offer meals, you need some sort of 24/7 emergency response in the home. I do think that one of the biggest challenges going forward is going to be around caregivers, and what is the conversation that needs to happen with folks to really consent them as well for enrollment, and what do we think about how do we make sure that, you know, these are the 15 things that are offered in a hospital at home program, and none of those 15 things are things that the caregivers are required to do. Yes.
Terrific presentation.
No, thank you.
And glad that you're back.
Thank you. Maybe I'll stay. I know, but you guys have tough questions. Go ahead.
I wonder if you could just paint for us a picture of like the ideal patient for hospital at home, and then maybe paint for us a picture of patient who's not ideal.
Right. So when we first built hospital at home at Sinal, we picked those patients with traditional medical diagnoses, CHF, who we knew would do well in the program, who we expected to discharge back to the community. But what we found is that providers were calling for lots of patients who we know as we called hospital averse. So patients who really needed additional evaluation but didn't want to go to the hospital. And so I personally see one of the patient populations to most benefit from hospital at home, if not ideal, as those individuals with multiple chronic conditions, often an end-stage diagnosis, be that cancer or heart failure, who really don't want to go to the hospital again. They know what that's like, and they don't want that experience, but they do want to be treated. One of the patients that I took care of in New York was somebody like that. She had metastatic GI cancer, and she had pneumonia. So she just wanted antibiotics, but she also wanted to be home with her family. And so for her, it was a conversation. How do we continue to have those conversations about hospice and goals of care? And then she eventually enrolled in hospice and passed away at home. And so for me, the ideal patient is that individual who really has the caregiver support and the desire to remain at home. A patient who would not be ideal. Actually, I want to tell you one more patient who I thought really benefited. It was a gentleman who had whose wife had dementia, and he had a toe infection that we were not sure if it was osteomyelitis. So he really needed additional imaging to figure that out, but he didn't have a caregiver for his wife. And so being able to be in the home with him and have social work involved allowed us to help make that transition for him so that he could start to get IV antibiotics in the home and then come into the hospital when it was the right time. The patients that we saw, or a patient I can think of who did not do well, was somebody who was single, did not have a caregiver, and had new ADL needs. Yeah, and once you offer 24/7 home health services, those ADL needs don't just disappear at the end of a hospitalization. So what's the next step? Yeah, great question.
One final question.
Yes.
From the Zoom world. That was excellent talk.
Oh, thank you.
How are you thinking about specialty consultation in the home?
Yes.
Video consultation, e-consults, and what will be an acceptable return rate?
So initially for consults in the home, they'll be primarily by telemedicine, so by e-consults for our program. And then an acceptable return rate, on average, you're seeing about 8 to 15%. And so for our pilot, we're aiming for less than 20% as we are learning and feel like there is room to grow and improve. But in general, you should be seeing about 8 to 15%. And just to be clear, that number should not be zero, right? If that number is zero, then you're not admitting patients who could really benefit.
I guess
Yes.
the last thing I know this is kind of a question, but it's like I went to some of the preliminary meetings next year about this tech program and how the disabilities are written. And I think one of the challenges I brought up was you seem to have been very fortunate in securing this vendor relationship in the community, because in a community like this, it's incredible. We don't even have enough workforce to serve the hospital, much less finding people in the community to do this kind of work well. And so I just worry that certainly in this community, it might be more challenging. So geography has like sort of the socioeconomics of the geography.
Yes.
Some things it's not, big scale.
Absolutely. And I don't want to minimize how difficult it is to find the right people for this work. As you can imagine, if you work with a home health agency, they're really great at doing wound care and doing assessments, but they may not be great at putting in an IV. And then if you work with nurses who are used to working in the hospital, they're really uncomfortable when they're in the home and things aren't the way they're used to be. So you really need to find the right people to work in your home health agency. And by right people, I mean mostly like nurse practitioners and RNs who have maybe more experience and usually in the acute care setting, but are looking for something new. And one of the ways I think some programs are staffing, or at least trying to find staff for their hospital at home programs, is around pitching this to nurses and nurse practitioners who've been out in the world for a while, as this is a new challenge, a new opportunity for you. But you're right that I think all across the board, it's difficult to staff in healthcare settings.
Thank you so
Thank
much.
you. Thank you.